Okay, Assalamualaikum. You can start.
Okay, Assalamualaikum. My name is Nabila. So today my group will present the CPC regarding the urolithiasis. Next. This is our table of contents. Okay, next. Okay. For the case presentation, I will present about it. Okay. So my patient, Mrs. S, a 60 years old pensioner, Malay married woman with underlying hypertension, was admitted to surgery ward due to right lumbar pain for 1 day prior to admission. She was apparently well until 1 day prior to admission when she experienced a right lumbar pains that was sudden in onset, and the pain occurs persistent and it was worsening in nature. And this was her first episodes, and the patient described the pain as dull aching in nature, and it did not radiate to the other part. The pain score was 9/10, and the patient described the pain as aggravated upon fluid intake. But the patient did not take any medication to relieve the pain. And the pain caused difficulty to perform household chores, but it did not disturb her sleep. And apart from that, the patient also experienced gross hematuria, which occurs throughout the urinations, and it occurs for 3 episodes with no blood clots and no anemic symptoms. And then the patient also experienced incomplete voidings, but there's no other obstructive symptoms and no irritative symptoms. Next. Okay. And then otherwise, the patient does not pass out any urine or stones. There's no dysuria or fever, and no constitutional symptoms. And there's also no nausea or vomiting, and the patient has no history of trauma. Regarding her diet, the patient claimed that she drank an adequate volume of water every day. She also took a normal diet that is not rich in red meat or seafoods. Regarding her past medical and surgical history, she was diagnosed with hypertension 5 years ago, but she was not on any medication because she defaulted to follow up at KK Permatang Badak. But she complained of no headache, chest pain, or principal attacks, and she also never undergone surgery before. Regarding the past drug history, there's no medication taken, and she also has no food or drug allergy. For the family history, she is the fourth out of 6 siblings. Her mother had underlying diabetes mellitus and hypertension. There was no history of malnutrition in the family, but she claimed that her 31 years old daughter has a right renal tumor. Regarding social history, she is a pensioner, married, and lives in Permatang Badak. She is non-smoker, not alcoholic, and does not involve in any sexual promiscuity activities. For the general examinations, on general inspections, the patient is a medium-built lady, conscious and alert. She was lying in a supine position, but she looked to be slightly in pain. There was pink bronchi inserted at the left horizontal hand with active infusion of non-vessel lines. There's no palmar pallor, and the capillary refill time was less than 2 seconds. The pulse rate is 80 beats per minute, regular rhythm, and good volume. There's no facial edema, no conjunctival pallor noted. However, the tongue is slightly coated. There's no lymphadenopathy and no bilateral edema. Regarding the vital signs, the blood pressure is high at 148/92, but otherwise, the respiratory rate and the temperature with the oxygens are all normal. Next. Okay, for the abdominal examinations, on inspections, there is no abdominal distensions. The abdomen moves symmetrically with respirations, and there's no abdominal scars. And then on superficial palpations, the abdomen is soft, but it was tender at the right lumbar regions. On deep palpation, there's no guarding with tenderness or mass that can be felt. Liver and spleen is not palpable, but the right kidney can be palatable, and the right renal punch was positive. And upon percussions, the abdomen was resonance, and shifting downwards was negative. And then upon auscultations, the normal bowel sound was present and there was no aortic or renal fluid that can be heard. Okay, for summary, Mrs. S, a 60 years old pensioner Malay married woman with underlying hypertension, was admitted to surgery ward due to right lumbar pain for 1 day prior to admissions. And it was associated with gross hematuria and also incomplete voidings. On abdominal examinations, there was tenderness at the right lumbar regions, bilateral right kidney, and the right renal punch was positive. So the provisional diagnosis is right urolithiasis because the patient presented with right lumbar pains, also gross hematuria, and also facial contact of liquid voidings. And then upon examination, also the right kidney is palatable and the right renal punch was positive. But however, there was no loin to groin pain. And then the differential diagnosis is first is the right urolithiasis. But however, in this patient, she presented with gross hematuria. And then the second one is right pyelonephritis, but the patient doesn't have fever, nausea, or vomiting. And then the third one is right, right renal cell carcinoma in view of the age of the patients. But the hematuria that presented in this patient is painful, and also upon abdominal examination, there's no marks that can be palpated. Next. Okay, so investigation that is done in this patient is first the full blood count. It revealed a normal hemoglobin, but the white vessel count is high. And then the second one is renal function test. The GFR is slightly low, but otherwise the electrolyte and the urea and the creatinine are all normal. And the liver function test reveal the liver enzyme is increased. The serum calcium and uric acid are normal, and CRP also normals. And the urine full examination and microscopic examination reveal the presence of hemoglobins, ketone, and also there is red blood cells and white blood cells in the urine. And then upon ultrasound of the kidney, urethra, and bladder, it revealed that the right kidney was mild hydronephrosis with proximal hydroureter. This might be likely secondary to distal obstruction or the post passage of the calculus. Next. For the management, the patient is admitted to wards, and the analgesia is given to the patients, which is IV tramadol and paracetamol. And then the patient is also given hydration with normal salines. And the oral chemolysis is given using the ural effervescent granules for gram. And due to the high blood pressure, the patient also given oral captopril. And due to the increased white blood cell, the patient is also given antibiotics, which is IV metronidazole and ceftriaxone. And next, the patient is planned for the citiograms and to come again 1 month after. So that's all for the case presentation.
Okay, so next we move to the introduction of urolithiasis. Next. So start with the anatomy of urinary symptom. It is divided into upper urinary tract and lower urinary tract, which is upper urinary tract consists of kidney and ureters, while lower urinary tract consists of bladder and urethra. Next. So urolithiasis is actually formation of stones or calculi anywhere in the urinary tract. It can be at the kidney, ureter, bladder, or urethra. And at the kidney, it also can be called as nephrolithiasis. Next. So this is the clinical anatomy. So stones can actually be passed spontaneously. But then there is 5 anatomic narrowings or constriction that might be difficult for stones to pass. But there are these 5 places, which is the first one is ureteropelvic junction, second one is crossing the iliac artery, and third is the juxtaposition of vas deferens or broad ligament. Fourth is when the ureter entering the bladder wall and at the ureteric orifice. So, but generally stones that is smaller than 5 millimeter can be successfully passed through these orifices. So next. So, urolithiasis in Asia, about 1 to 19% of population suffer from this urolithiasis, and male has higher risk to get urolithiasis as compared to female, and it has ratio of 2 to 1. And peak presentation is among middle age, between 30 to 60 years old, and there is high chance of recurrence of urolithiasis, and 10 to 30% of patients among the 3 to 5 years patients within the 3 to 5 years have recurrence in patient with calcium oxalate stones. Next. So these are four types of urinary stones, which is the first one is calcium stone, which is the most common one. 75% of patients come with stone has this calcium stone. And second one is true white stone. Third one is uric acid stone, and the fourth one is cystine stone. Next. So this is the etiology based on the type of stones. So the first one is the calcium stone, which is the most common type. It can be calcium oxalate or calcium phosphate. And the etiology is if there is a high calcium in the urine, hypercalciuria, oxaluria, which is high oxalate in the urine, and low magnesium in blood, and also low citrate in the urine. And this can be due to this can be influenced by the dietary intake, such as dietary intake that is high meat, high sodiums, and low in citrus fruit. And in the plain radiograph, the stone can appear radiopaque. And the second one is true white stones, which compose of magnesium, ammonium, and phosphate. And it presents as the renal staghorn calculi, and this usually caused by infection. So it is known as infection stone. The cause might be urinary tract infection with urea splitting bacteria such as Proteus mirabilis. And this might be due to the urease will hydrolyze urea into ammonia and carbon dioxide and then form the stones. And at the plain radiograph, it appear radiopaque also. And for uric acid stone, usually it occur in men, and it might be associated with gout. And the etiology the patient might take food that is high in purine, such as seafood, meats, organ meats such as liver, or vegetables such as spinach, and it can be appear radiolucent in the plain radiograph. As for cystine stone, this is we might suspect it in the patient with family history of urinary stone because it is actually autosomal recessive disorder, which is there is intrinsic metabolic defect that cause the failure of renal tubules to reabsorb cystine, lysine, ornithine, and also arginine. And this also appear radiolucent in the plain radiograph. So that's all from me.
Okay, Assalamualaikum. I will proceed with risk factor, pathophysiology, as well as clinical features of urolithiasis. Risk factors can be divided into modifiable and non-modifiable. For modifiable, diet plays a big factor in the formation of stone. For those who have a high diet, high in calcium, not just that, but also people who take low fluid intake, and also those who takes a high animal protein diet. And then those with medical conditions such as prior personal history of stones, and then patients with chronic kidney disease, hypertension, gout, diabetes mellitus, hyperlipidemia. These patients, hypertensive patients, diabetic patients, and patients with hyperlipidemia, they tend to get stones because they often have diet with high in animal derived protein, and also salt and also sugar. So all of these increases the risk of stone formation. And obese patients, they are insulin resistant, and diabetic patients, they have metabolic changes that is due to increased urinary calcium that will cause
stone formation because of increased urinary calcium and uric acid excretion. For drugs-induced stone is actually rare, which is about 2%, but the common drugs are like protease inhibitors, which are used to treat HIV patients. And then occupation, those who work in the steel industry, they are exposed to chronic lead and cadmium exposure, so they can get stones. And then frequent urinary tract infection, which I will explain after this. For non-modifiable risk factor, if there is a family history of stones before, then that person will have like 2.5 times higher chance of getting stones as well. And then climate, for people who live and work in a hot and humid place or country, they tend to get stones mainly because of dehydration. And then abnormal anatomy of urinary tract, like horseshoe kidney. Okay. Next slide. These are taken from the European guideline, so you can browse through the more in-depth risk factors of urolithiasis. Next. Okay, next. These are examples of drugs that can cause stones. Okay, next. The pathophysiology of urolithiasis, it is mainly due to there are actually few theories for urolithiasis, for stone formation, such as the free particle model theory, the fixed particle theory, but these theories are somewhat incomplete. So we are left with this kind of general pathophysiology of urolithiasis, which is supersaturation. So when there is dehydration, there is higher level of substance such as uric acid or calcium in the blood, the urine, it will be super saturated. So this will cause this will lead to nucleation. So nucleation is when crystals that the stone is composed of begin to compound together. They begin to aggregate and begin to collect together, which causes stone formation. So the stone, it may be retained in the kidney and causes obstruction later on. If the obstruction does not allow the passage of urine, it will cause hydronephrosis. And if the stones can also migrate into the ureter. So if it is small enough, it can pass through painlessly, seamlessly. If it is large, it can cause symptoms. And the right one is basically what Farah Anis has explained previously, which is how the struvite stone is formed. It is due to the urea splitting bacteria such as Proteus mirabilis, in which they will split urea into ammonium, which is the byproduct of urea breakdown. So this will cause the pH of the urine to be elevated, and it will cause precipitation of magnesium, ammonium, and phosphate, which will lead to formation of the struvite stone. Next. Okay, the clinical features, it depends on the size and the location of the stone. And the manifestation of the clinical features is mainly due to if there is obstruction, there is infection, and because of the movement of the stone. And patients present with similar symptoms, which may range from asymptomatic to critically ill. Next. So these are the general features. Patient may came to you with pain, hematuria, nausea and vomiting, and fever. So pain, it is usually quality in nature, but it can also be continuous. It is continuous when there is obstruction. So the stone doesn't move anywhere, so it causes a continuous pain. For colicky pain, it is mainly due to the peristalsis of the stone. The peristalsis of the urethral smooth muscle, because the stone, for example, when the stone is in the ureter, when it tries to pass through the ureter, right? So it will cause pressure inside the lumen, and it will cause increase in the luminal tension. So that will further stimulate the submucosal stretch receptor, which will in turn cause pain. Okay, so yeah, because of the peristalsis, it causes colicky pain. And then hematuria, nausea and vomiting. So nausea and vomiting can occur in urolithiasis because of the common innervation pathway between the kidneys and the GI tract through the afferent of the vagus nerve and the celiac axis. Fever when there is infection. So on physical examination, usually the abdomen is soft and non-distended. If the stone is at the uretero-pelvic junction, then the patient may present to you with there may be flank tenderness. If the stone is at the uretero-vesical junction, then there may be tenderness at the groin, scrotal, or labial area. And then because of the pain, the patient can appear restless. They shift around because they are uncomfortable. And in severe cases whereby there is urinary obstruction, which may become source of sepsis, the patient may seem disoriented because of metabolic abnormalities or hemodynamic instability. For pediatric patients, they may come to you irritable, crying, and vomiting. And then you can also observe any physical sign of complication like severe intractable pain in case of infection. Next. Clinical features, like I mentioned previously, it depends on the size and location. So if it is renal stone, the patient may present with renal colic, hematuria, loin pain, secondary infection from UTI or sepsis, and passing out of stones. For urethric stone, there will be urethric colic, which can radiate to the scrotum or labia, and there may be also nausea and vomiting. For bladder stone, patients may present to you with irritative bladder symptoms such as urgency, frequency, nocturia, or dysuria, and then pain which radiate to the tip of the penis, or obstructive symptoms such as hesitancy, incomplete bladder emptying, and post voiding dribbling, or also slow urinary stream. Okay, next. Okay, that's all from me. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Ni'al Musawar bin Muhammad Amran, and I'll be presenting on the approach to the diagnosis of urolithiasis. So, generally speaking, in making a diagnosis for urolithiasis requires a thorough history taking as well as physical examination, and combine two of this with the investigation or lab investigation or imaging test will get us a better understanding of the disease and the diagnosis, and which will make us getting closer to diagnosing patient who have stones or urolithiasis. So in this subtopic, I'll be covering more on the investigation part, as my colleague previously had explained upon about all the clinical features of urolithiasis. So there are three important tests that is needed for the diagnosis of urolithiasis, which includes a blood test, urine test, as well as imaging. However, all of these tests, we do not send everything to make a diagnosis of urolithiasis. So it depends on the situation as well as the presentation and the signs and symptoms that the patient presented to us. So for example, just now in the case presentation, the patient is presented with acute loin pain associated with hematuria and as well as signs and symptoms of urinary obstruction. So in this case, in this case, we might suspect some pathology which includes of renal colic or urolithiasis, RCC, or even nephrolithiasis. So in view of that, in view of our differential, we choose what are the important tests that needs to be sent. So routinely we will send for FBC, for renal profile, something like that. So in FBC, what we will need to be looking at as the patient is presented with a hematuria. So what might need to look for the HB levels, whether the patient had anemia secondary to to the hematuria. And then we might want to look at the white blood cell level if the patient already if the because it is important in case of a urolithiasis infection can be the cause of the stone, or even urolithiasis can cause and can further complicated with an infection which can leads to sepsis. So it is important for us to know what is the white blood cell level in this patient. Other than that, we also need to know about the renal profile, because we want to know what is the current status of the patient's kidney or renal function. We want to know how much is the EGFR, how much is the creatinine clearance. Where we want to know whether this patient already complicated with some sort of acute kidney injury due to the urolithiasis, due to the stones. Other than that, serum calcium, serum calcium is one of the blood tests that can be considered, that needs to be considered as well, because one of the etiology is there is a hypercalcemia which causes precipitation that further leads to stone formation. So we want to know whether there is an increase of the serum of serum of serum calcium level. And increase of serum calcium level also indicates some sort of pathology that involves with the parathyroid hormone. So we also need to take as well the serum parathyroid hormone, so that we want to know whether this is a case of a secondary hyperparathyroidism or primary hyperparathyroidism. Okay, so other than that, C-reactive protein and coagulation profile, based on the European Association of Urology, CRP and coagulation profile is also important. However, the importance is however these two blood tests can be considered or delayed upon if we want to take them. If in case of emergency, if in case of patient is in distress or presented with a severe pain, the ones that I had bold is much more important to take first rather than the CRP and the coagulation profile. As for the urine dipstick is important, so that we want to know if there is presence of any gross hematuria, whereas the urine FEME is is very significant, because it has a lot of information that it can tell us, such as in the urine FEME, you want to look for any presence of the leukocyte and nitrite positive, which can which can indicates of presence of urinary tract infections, if there is any presence of urinary crystals, and as well as we can also look at the pH levels. Because in the pH level, if the pH is more than 7, the high likely presence of there is a high likely presence of urea splitting organisms, such as mentioned before, Proteus, Bacillus, Klebsiella, and so on. Whereas if the pH is less than 5, it might indicates that there is a presence of uric acid stone. So the urine FEME has a lot of information that it can tell us. Whereas the urine CNS, if we establish that the patient, we establish that this patient had ongoing infection or had a urinary tract infection or urosepsis, then urine CNS needs to be taken, so that we want to know what is the causative organism, and we want to treat the infection with the specific antibiotics. Whereas the 24-hour urine collection, based on the European Association of Urology, 24-hour urine collection is much better used if we want to know the cause of the stone, so that we can prevent recurrence, and it is much more beneficial to those who have a high risk of stone recurrence, to the patient who have high risk recurrence. So it's better frequently used in follow-ups of the patient. However, in with regards to the stones itself, the diagnostic test is much more with the imaging test. So such as the ultrasound of the kidney and bladder, the X-ray of the kidney, ureter, and bladder, as well as the CT scan of the KUB or CT urogram, and as well as the intravenous urogram. So let's go much more detail with the imaging, since it is an important test to diagnose uh, urolithiasis. So ultrasound KUB, if you remember the case presentation before, the first imaging that has been done to the patient was ultrasound of kidney, ureter, and bladder. Because based on the guideline, ultrasound is considered as the primary diagnostic imaging tool, and as it is safe, reproducible, and reproducible image, and it is inexpensive, and much more importantly, it has no radiation towards the patient, and it is readily available right now and has been widely used in every hospital, especially in Malaysia. So what we want to look in the ultrasound scan is that we want to find the distinct features of stone is there is a presence of acoustic shadowing. So if you can look at the image over here, there is uh, if you can look closely at the image at the superior part of the ultrasound image, there is a stone or an echogenic stone, and you can see below the stone there is some sort of image defects. It looks like a shadow. So that is uh, distinctive features for stone. How, so however, despite it is widely being used in all hospital and is being the primary diagnostic imaging tool, but it's not reliable to detect smaller stones, especially stones that are in size of less than 5 millimeters. So in view of that, actually, the gold standard based on guideline, the gold standard test for urolithiasis, actually not for urolithiasis as well. We use the no contrast CT scan, but uh, but for the sake of this presentation, the non-contrast CT scan of the kidney, ureter, and bladder is considered as the gold standard test because it can detect even the smallest stones, and it can reveal other pathology as well if the patient if it turns out that this patient has symptoms that is similar to urolithiasis, but turns out to be other pathology. So CT scan can also show that. So it gives us a quicker time to reach our final diagnosis. And it is also it also in non-contrast CT scan, it also avoids the use of contrast materials, because contrast materials, it will appear as whitish in the image. So we don't want to use contrast because stones can also appear whitish in non-contrast image. So that is why we use non-contrast CT scan. And other than that, CT scan, another advantage is that it can determine the diameter, density, and inner structure of the stone, the skin to stone distance, as well as the surrounding structures of the stone. However, the disadvantage of non-contrast CT scan is that it is relatively expensive, relatively expensive, and although it can detect the smallest stones, even less than 3 millimeters of size, it unable to detect stones that are radio lucent, which one of it is the Indonave stones, which is um, stones that are produced by ingesting by precipitation of the uh, medication of antiretroviral drugs. So other modalities that can be used in detecting for urolithiasis or stones is kidney ureter, X-ray of the kidney, ureter, and bladder. So about 85% or 90% of renal calculi are radio opaque, except for uric acid or Indian stones, as mentioned earlier by previous presenter. So usually the X-ray is not used for diagnosis because we want to use the much more accurate and sensitive and specific test, as well as and yeah, specific, sensitive, and much quicker uh, to diagnose stones, so that we can manage this patient early. So usually for the X-ray, we usually use for follow-up or recurrent screening. However, the disadvantage of the X-ray is that classifications such as phleboliths or vascular classifications can also appear radio opaque, and it might be confusing uh, to some. Last but not least is the intravenous urography. This is actually an old modalities used to detect for urinary stones. So previously, before non-contrast CT scan, this is the gold standard test. But now we have the non-contrast CT scan. So intravenous urography is not widely used, except in the case where non-contrast CT scan of the kidney, ureter, bladder cannot be able to show the presence of stones. So in this, such as in cases of the Indian stones that I mentioned earlier, so intravenous urography can be quite useful in this situation, because intravenous urography is a type of modality where we inject a contrast dye into the intravenously. So then and then we take a serial image of plain radiography, so that we want to see what there is any filling defect, which might indicate any stones. So in the special groups such as pregnant mothers as well as children, we want to use modalities or imaging tests or diagnostic tests that are relatively safe to them, which means we want to limit the radiation exposure to this group of patients. So especially in pregnant mothers. So based on the guidelines of European Association of Urology, um, ultrasound is the first line imaging modalities that can be considered. MRI is considered as the second line, and non-contrast CT scan is the last option if the above modalities are unable to show any presence of stones. And for us, as meanwhile for children, stone analysis or 24-hour urine collection for stone analysis is one of the tests that is considered among children, because we in children's, if patients in a if a pediatric patients presented with stones, there must be some sort of pathology going on with their urinary tract. So we want to know about the cause. What is the cause of the stone? What is the cause of the stone formation? As well as we also need to screen or to find out if there is any underlying pathology that this child might have, such as the most common one are the vesico-urethral reflux or uretero-pelvic junction obstruction, as well as neurogenic bladder. So this uh, need to be ruled out. This need to be investigated for this pathologies if we want to manage children child pediatric patients. So ultrasound is also used as the first line imaging, whereas based on the guideline, ultrasound is also used as the first line imaging, as well as followed by the KUB X-ray or low dose or non-contrast CT scan if the ultrasound proven is not useful. Just to remind you all that in dealing with a pediatric patient or in pediatric patients, when doing this kind of test, they might be uncooperative, especially when doing the CT scan. So we might want to we might need to sedate the patient so that we can do the test properly. So, okay, that's all for me.
Okay, I'll proceed with management of urolithiasis. Next. Okay, so for the management of the treatment of urolithiasis is based on many parameters, and it is individualized by for each patient. So if patient is presented to the emergency department, so we need to do the primary survey first. So we check the airway, breathing, and circulation. So proceed with the management for acute management of urolithiasis. So the first one is adequate pain relief. So we may administer analgesics. So the preferred one is actually NSAIDs, such as diclofenac, to relieve the pain. Some of the others medication can also be given, such as petidine as well as paracetamol. So the next one is vital signs, hydration, and EGFR should be monitored for the patient that presented in emergency department. So EGFR is actually for monitoring of the renal function of the patient. So we need to also make sure the patient has have IV access to give a fluid. So the next one, if infection is suspected in this patient, we need to administer antibiotic and proceed with the stone removal and treat the cause. Next. So most of the urolithiasis is actually managed conservatively. Studies mention that majority of the stones will pass within 6 weeks or 40 days. And about 60% of stones sizings 5 to 7 millimeters should pass with conservative management. And however, there's mention that stone expulsion decreases with the increasing size of the stone. So the management is actually depends on the size of the stone and the presentation of the patient itself. However, if the conservative management is not succeed, we can proceed with medical pharmacological management. Next. So this medical expulsive therapy should only be used in informed patient whether active stone or surgical removal of the stone is not indicated. So medical expulsive therapy seems to be very efficacious for treating patients with urethral stones, and also benefit to those who have stone more than 5 millimeter that is not passed during conservative period. So the medical expulsive therapy is to facilitate the spontaneous passage of urethral stones. Some of the pharmacological drugs that can be used are alpha blocker, calcium channel blocker, and phosphodiesterase type 5. So what did alpha blocker do? So alpha blocker, it actually relaxes the muscles in the urinary tract and makes the stone to pass into bladder more easy. While the calcium channel blocker and it decrease the urine calcium, and PDE5 it causes the ureteric relaxations that makes the stone to pass easily. So for oral chemolysis, so this is the drugs that the effectiveness, or we known as the urinary alkalinizer. So the effectiveness of these dissolution agents is depends on the stone surface area as well as the stone type. So for this oral chemolysis, stones that compose of uric acids can be dissolved by this drug. So it is more effective in uric acid stone. Some of the examples of the oral alkalinizing agent include sodium or potassium bicarbonate or sodium citrate. Okay, next. So, what are the indications of active removal of stones? So, we need to intervene these stones. The indications are stones with a low likelihood of spontaneous passage, or a big size of stones. So, patient presented with persistent pain despite adequate analgesic medication, persistent obstruction, and renal insufficiency, as well as infections. Infections may also may also indicated for active removal of the urethral stones. Next. So what are the treatment modalities that we have that could remove the stones? So among of the modalities are stenting, ESWL, PCNL, and uteroscopic lithotripsy and open surgery. Okay, next. So the first one is stenting. So stenting is indicated when patient presented with acute renal obstruction, and we need to administer or help the passage of stone fragment, prevent the ureteric obstruction and pain, and it is a decompression to prevent permanent renal damage or worsening the infection. So how does this function? So it is a soft, hollow plastic tube which placed temporarily into the ureter, and the stent allows the drainage around a stone or can speed up healing. So it helps to prevent the ureteric obstruction. So when there's stenting, it drains the urine from the kidney into a bag outside of the body. So it bypasses the ureters and bladder. Okay, next one. So the next one is ESWL. So it is a non-invasive method of destroying stones that externally apply shock waves from outside of the body that will shatter. So is initially the stones is in a bigger size. So we apply the wave. So when there's the wave, the stone will be fragmented into small pieces. So after the small pieces, it can pass through easily. So it is to treat small to medium size of kidney stones. However, in patients who are pregnant, obesity, or have bleeding diastasis, it is contraindicated to do ESWL as if the patient pregnant, it may cause the detachments of the placenta. However, in this ESWL, we may miss some of the fragments during passage of the stone. Some of the complications of ESWLs are ureteric obstructions, still present, UTI, transient hematuria, sepsis, and hemorrhage. Okay, next.
Right. Assalamualaikum. My name is Faiz and I'll be continuing what we have on the surgical modalities. So another one we have is ureteroscopic lithotripsy. So previously Najwa mentioned extracorporeal lithotripsy, which shoots the shock waves from outside. But this one is more complex. You insert a ureteroscope into the ureter, and then from then on it'll emit a laser, holmium YAG laser, and that will cause the stone to be to fragmentize into smaller pieces. And yeah, so and once you've already make the stone smaller using the holmium or using the laser, then you may place a double J stent, which is that image that you see, that tube. It has the J's at the end. Yeah, that's why it's called double J stent. And what it does is that it facilitates the drainage of the stone from the ureters. And also this procedure is lithotripsy, meaning that it has the name lithotripsy. Lithotripsy means using the shock waves to for the stone fragmentation, to make the stone smaller. And compared to the previous one, which shoots the shock waves from outside of the body, this one is more effective than that for stones measuring more than 10 millimeters. However, the previous one is not invasive. This one is minimally invasive, and some complications you can get being this procedure is that ureteral injury or stricture. Yeah, next. Okay, and now for stones that measure more than 20 millimeters, we have percutaneous nephrolithotomy. As the name implies, this is a percutaneous. This is percutaneous. So what is done here is that a needle is inserted percutaneously into the kidney, and then insertion of a guide wire, and from that guide wire you can insert your nephroscope. And once you've inserted the nephroscope, you can visualize the renal pelvis and the other structures. And if you have a stone, you can do lithotripsy to break down the stones into smaller pieces. And yeah, oh, and I should mention that before this procedure is done, pyelogram is conducted, meaning that before this procedure is conducted, we will insert a contrast using a tube that enters from the urethra to the bladder to the ureter, and then we'll shoot the contrast, we'll confirm the location of the stone, and then only we'll insert the needle, the guide wire, the nephroscope, and the finish and break down the stones. And once you've already retrieved the stones, there'll be another round of pyelogram. We'll insert the contrast through the nephroscope one more time to confirm, to detect if there's any missed stones that we miss. Yeah. Next. And finally, we have open surgery. But open surgery, from what I've read, it's not so common. It's not common or rarely done nowadays. There's nephrolithotomy, which is removal of stones by opening the kidney parenchyma, or pyelolithotomy, which is removal of stones from opening the renal pelvis. And also there's the American Urological Association recommends that if the kidney is no longer viable, you can actually do nephrectomy. Yeah, just a recommendation. Next. Okay, and this is from this is just a flow chart, not flow chart. Yeah, it's just a chart to select which surgical modality may be used. This is from the Korean Urological Association, and yeah, so what they recommend is less than 10 millimeters. Of course, if it's 5 to 7, as mentioned by Najwa, you can do conservative management. But if it's really symptomatic or problematic, then you can do shockwave lithotripsy, which is shooting the shock waves from outside. And then from 10 to 20 millimeters, you can still do a shock wave from outside. But then, using a ureteroscope and emitting the shock wave from the ureteroscope, it has been found to be more efficacious, and the patients have a higher stone-free rate. Yeah, the less chance of stone recurrence. And then finally, if it's more than 20 millimeters, you can do the percutaneous nephrolithotomy, which is inserting the needle, the guide wire, and the nephroscope. Yeah, okay. Next. And of course, we monitor for the possible the complications of UTI, fever, nausea, vomiting, all these signs of UTI, dysuria, pyuria, not really pyuria, but actually cloudy urine and foul-smelling urine. I don't know why I put pyuria, must be accident. Monitor for signs and symptoms of sepsis, and also when follow-up, there may be late complications, ureteral stricture. If you decided to use a ureteroscope, there may be a ureteral stricture. Next. And of course, it'd be much more beneficial from surgery if there is no recurrence of stone, right? So some advice that you can give to the patients is, of course, adequate fluid intake, so we don't make the urine concentrated, which will predispose to more stones. Maintaining a healthy BMI also helps. Adopting a healthy diet and avoid these foods, oxalate-rich foods, which forms calcium oxalate stones. Avoid sodium-rich foods because that will increase the urinary secretion of calcium. And purine-rich foods, which predispose to uric acid stones. And also avoid prolonged states of immobilization, because that will cause more urinary stasis, and in the long run, that may cause bone resorption. If you don't utilize your bones, it will cause bone resorption, more serum calcium. Okay, yeah. Next. Okay, I think that's all from me. Thank you.
And the discuss on lifestyle changes and what we call lifestyle modification for stone disease treatment. Because all these stone, whether dia besar ke kecil ke, you need to correct those things. Tak ada You must remember, although you operate, you still need to manage their lifestyle, to change their lifestyle, and to modify the diet as well as fluid intake to make sure the stone is not recur. Okay. Advice. Advice. What you mean advice?
Encourage.
That's why it's not advice, it's treatment. Because if you, what we call, you don't change their lifestyle or their modifiable factor. For example, you treat the high uric acid level, you treat the calcium problem. Maybe patient have hypercalcemia because of parathyroid, other disease. The stone will recur within a few months. So what I want to see here, actually, when you manage the stone disease patient, there are two components. One, actually, active stone removal. If you fail to understand that, you just flow whatever your friend mentioned. It just everything is copy paste. So it not flow thought of a perawat atau a doctor or even what we call medical team. So when patient with stone come, as your friend said, first, what the chief complaint? If pain, then manage the pain. Yes, you highlight just now or give this painkiller. But if patient not pain, why you want to manage pain? So first is manage the chief complaint. What the chief complaint? Is patient came with complication, high grade fever, chill and rigor, no pain at all. Why you manage pain? Still is not indicated. Manage the chief complaint. It can be the chief complaint. It can be a complication of stone disease, which is acute renal failure because of obstructive uropathy. It can be urosepsis because of secondary infection after obstruction. So that's flow thought of the doctor. When patient come, what acute problem, that tackle that one first. It's not so okay, we need to do CT, then straight away yes, the PCNL or whatever. No. Okay. The first thing is manage how it's presented. The thing is your presentation is not correlate with the case presented. Case presented then shows what have been done. But I think you should, maybe it's not enough time to present all type of stone, renal stone, urethric stone, or bladder stone. But I think you need to relate with the clinical scenario because this session is what we call case presentation by right. So you just discuss how you manage those cases based on the real scenario. Okay, that one. Manage a patient based on what the complaint come. So manage the patient based on which is acute condition. If acute condition is sepsis, you may not manage anything about the stone. You may send to ICU to stabilize the patient. May need intubation because of lung failure or respiratory failure because of sepsis, or may need to go for medical ward because patient have acute renal failure which require dialysis. So that very important in mind of surgeon. We or doctor, we need to manage the patient according to the chief complaint presented. Okay. Then once the what we call acute problem have been resolved, you must remember to handle based on immediate treatment you need to do. So certain book they call temporary procedure. Patient with obstructive uropathy secondary to stone. What is the temporary procedure? You may need to stented, you may need to put in nephrostomy. You cannot do ESBL, you cannot do PCNL or even URS because you need to settle the acute problem first. So that's why when you present in terms of treatment of stone, one is the what we call chemolysis or medical treatment for stone, two active stone removal, three actually temporary procedure for a stone. It's very important. So if patient come with acute obstructed, with renal failure, you send to medical, they dialyze, then after that you need to bypass the obstruction in mean of nephrostomy or stented. Then the last session we call definitive treatment for the stone. Whatever you present, actually definitive management of the stone, which sometimes majority of center in Malaysia not even do it because they don't have equipment, they don't have what we call specialty. PCNL, ESWL, even RIRS, they don't have the specialty. So because the way you present, it seems that you can choose based on size of stone, based on this list. You understand? Well, I want to highlight that you may have all the content here, but you don't have the flow thought of managing patient. That's very important. Okay. So in as a medical officer or medical doctor, you must know how to manage a patient. Then you see whether you can do in your center or you need to refer. If patient acute obstructed, majority center have dialysis, they need to dialyze. You bypass with stenting. Majority surgical team in Malaysia can do the stenting, or they ask our radiology clinic to do nephrostomy. Then if they don't have available facility or specialty, they do imaging and refer based on the imaging. So if the stone 2 cm or 3 cm, they may refer for PCNL. It's less than that, they may refer for ESWL and or whatever other option available based on the stone size and site of the stone. So that's what very important as medical doctor. If this patient, for example, 2 cm stone came with high grade fever, you say, oh Pak Cik ada stone besar kena buat PCNL, kita buat surat hantar ke major center. That patient will go back and collapse at home because of urosepsis. You don't manage the acute problem. So by right, oh Pak Cik demam, kita rasa Pak Cik ada complication of stone ni, Pak Cik kena masuk ward kita dulu, kita akan rawat. Bila dah okey, kita akan hantar ke tempat yang boleh buat rawatan untuk tekanan. That's a way of thinking you need. So when you discuss about treatment, the first is, as I mentioned, non-complicated stone. Most of time we go for what we call medical treatment of stone, or if the stone big but non-complicated, you go for straight away definitive treatment. It's whatever you present based on size, site, or whatever. If complicated of stone, you manage the complicated stone. Most of time, surgical team go for temporary procedure, whether nephrostomy or stenting. Then, when patient recover, we go for definitive treatment based on site and size of the stone. Anyway, all these stone patient will underwent medical treatment, what you call part of the medical treatment. Maybe not whole list what you give, because the patient normal uric acid, we don't give allopurinol or manage the uric acid part, but the normal what we call modifiable lifestyle can need to be changed. That's very important in management of stone. Okay, as I mentioned, you have everything, but you don't have flow thought of managing patient. You just get from book or this size based on that. You do PCNL, ESPL, RS. For us to assess whether you safe to be a doctor or not, it's not this, because we know this is a very high specialized area where you just need to know what the name of that procedure. For example, PCNL, not many centers do PCNL, but you know if big stone, you can need to do PCNL. And then if you may see those patients in Temelloh or whatever, you can send those patients to the center like HTA or in UIA. So that's limit of, knowledge. If you know more, is better. But the most important part is flow of managing patient with stone. Okay, any question?
Prof, I have one question. Is ureteroscopy and RIRS the same thing, or is it different?
Okay, actually it's same. Only thing is we call URS is ureteroscope, but in general we use semi-rigid. If you use old pictures, they use a rigid scope. which cannot reach the renal pelvis. You only can handle the urethric stone. RIRS basically flexible ureteroscopy. So if you read different book, they will use different name. If you name URS is ureteroscopy, RIRS basically flexible ureteroscopy. The advantage of RIRS, they can enter the renal calyx to identify, to handle, or to fragmented the small stone in the renal calyx. That's the only different.
Thanks.
But in majority of book now, the name become, instead of flexible ureteroscopy, they go for RIRS because it's very expensive scope. So we don't use that flexible scope for ureteric stone because we may damage the scope and you can do renal stone with the scope. So we just preserve that flexible ureteroscopy scope to be used to handle the intrarenal stone. So that's why the name become RIRS, retrograde intrarenal surgery. So that's why nowadays, basically, when you talk about ureteroscopy, is URS, which is stone in the ureter, whereas RIRS, basically the stone in the kidney, handling from below. It's not like PCNA, handling from above. Okay, any other question? Anything? Anybody want to ask any question? So, when you have the long case in your exam, the patient have stone, as I mentioned, manage the stone based on the presentation. Patient came with pain and acute renal failure. Manage the pain, manage the renal impairment. The only way to improve the renal function, the only way to quickly improve the renal function is dialysis. You stand, sometimes it takes 1 week or few weeks to improve the renal function. But you do stenting after hemodialysis. So creatinine 500, 700, you dialyze the patient, then do stenting because we hope patient generally recover from acute renal failure based after dialysis. Then the stent will help to clear the obstructive uropathy and make sure the renal function recover. Okay, anything else?
Prof nak tanya. I have a
Okay.
question. If we do stenting after hemodialysis,
Yep.
how long after hemodialysis? How long do we wait to do stenting? Ke dia buat urgent lepas dia after hemodialysis, after everything okay, then straight away stenting. Is it like that, Prof?
Okay. You learn that the systemic causes will cause systemic problem. For example, acute renal failure is systemic. It can cause various other problems. Nausea, vomiting, sometimes deteriorate, or what we call mental retardation because urea entered the brain. Stenting is local problem. So you want to tackle which one first? You need to tackle the systemic first. So after dialysis, patient recover, you stent, you hope the renal function will be recovered, but nobody knows if we recover or not. Nobody knows when it will recover. Because sometimes the kidney already obstructed for years because patient tak datang-datang kan. Dia obstructed until at the end, it completely obstructed, baru patient datang. So that's why you just dialyze to treat the systemic problem. Usually patient will recover very fast. Then baru you stent, then you kena cakap patient, wallah alam, saya tak tahu. Saya pun tak tahu bila pakcik start block. Tapi kita berusaha. So sometimes after 1 or 2 days, it recover because patient recently obstructed. That's why the history is very important. If patient kata tak pernah sakit sebelum ni, baru minggu lepas sakit, most likely we very fast recover because we know it just recently obstructed. But actual, nobody knows. If those type of patient, renal function never recover after you stent, it means patient go to end-stage renal failure. Is it your fault? Because patient not come for checkup, never have been, because in general, in our Ministry of Health system, there is clinic warga tua, kalau orang tua lah. Kalau orang muda lagi, actually after having any pain, they need to check up. So every 6 months, patient have take all the necessary, which is renal function, liver function, and basic cardiac workup. So by right, if all our senior citizen follow the system, we have baseline. So we should know that patient already have chronic renal disease before get complete obstructed. But we cannot say we just said we never know if we recover or not, because we don't know when it started to be complete obstructed. Okay.
Okay.
Anything? Any question?
I think no more question, Prof.
Okay, if no more question, we can end up our session. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof.
Waalaikumsalam.